Zainab and Zoa worked on the on handling mental health services through telemedicine in a small community in KPK called Dadar, which is very, very close to my heart. It's a mental asylum, which is in the remote areas of KPK, and it is the main mental asylum for patients from all the regions above KP and below KP as well. The people from Gilgit-Baltistan, people from KP itself, people from Punjab and Karachi go to that area. An interesting bit about that hospital is also it was one of the two places that Qaid Azam was to be taken to when he was ill with TB in his last days. And unfortunately, there wasn't a road in Dadar, so they took him to Ziyarat. So they did this research on the patient data we had from our mental health services in that community, which I think is very, very beneficial and can be used for a lot of future researches as well. So thank you, Zainab and Zoya, for your work on that. I think what Salman and Zishan did was particularly very important as well, because we always talk about the barriers and the issues faced by patients during telemedicine services, but what they worked on was something very unique, is the barriers and facilitators for doctors who are doing telemedicine services, and they'll have some great insights to share as well. And for Shumail, we selected a case study because he was doing it alone. And that case study was based on one of the most interesting projects during COVID-19 that Sehat Kahani did. We provided tele-ICU services in partnership with all the 4 provincial governments, the federal governments and UNDP across Pakistan, connecting critical care specialists to patients through staff intermediaries in ICUs. And Pakistan has 70 critical care specialists for a huge population. So the project itself was very useful to people in COVID and ICUs, and I think Shumail did a great job in writing a case study on it. He also took on some additional responsibilities in doing some competitive analysis and SWOT analysis for Sehat Kahani, because we also wanted some of them to work on the projects or the history of the company itself. So all in all, we had a great experience. We also do speaker sessions for these fellows. We try to engage them through videos and presentations about Sehat Kahani, about our work. But I think they were a great group of fellows, really interested to learn. And I'm really happy and excited to hear their presentations now and for the future cohorts who will be coming in. I really hope this time they can come physically and actually take the flavor of working within Sehat Kahani and working with us in a physical space. Because one of the challenges and barriers you always face is the great time difference that is there, which becomes very late for the fellows or for the Sehat Kahani members to work in. But I'm sure, and there are a lot of Sehat Kahani members who are buddies to these fellows here. So we have Nida, we have Yusra, we have Ramazan, I have my co-founder Ifat as well. And I think together we made a great team who pulled off these 3 research projects together. It seemed for a while that they're going to be a lot for the fellows to conquer, but I think they showed great resilience and strength in the end. So I'm really glad that they're presenting today, and good luck to all the presenters.
Thank you so much. And yes, let's keep our fingers crossed for the public health situation to improve so that we can actually have the proper experience of working with Sehat Kahani and in Pakistan, of course. So, so let's see. Why don't we go to Zainab first? And for each of the fellows, also, please just do a very quick introduction of yourself, kind of what are your interests, issues, why you wanted to do this fellowship, and where you are at kind of in your life. That would be helpful context, I think. There might be some future fellows on this call. Thank you. Go ahead, Zainab.
Hi, everybody. I'm just going to share my screen first really quick just to make sure that that's working. Do we see it, the slideshow?
Yes. Yes.
Okay, we're good to go. Okay, sounds good. Hi, everybody. My name is Zainab Faisal, and a little bit about me. I'm in my 3rd year at the University of Virginia, so I'm an undergraduate, and I'm double majoring in global public health and cognitive science. I'm on the pre-med track, but my concentration with my research is about mental health in South Asia. So interestingly, my work with Sehat Kahani on mental health fit really well with my academic interests. So I feel really fortunate to be able to research that, and because that is like what I feel that I want to do in the future. So I'm really grateful for that opportunity. And so I guess I'll just start with my presentation. So my project with Sehat Kahani addressed the identification of mental health disorders through real-time telepsychiatry services in Pakistan. And my partner was Zoya Chowdhury, but unfortunately she could not be here today. Okay, so I think I just did all this, so I'll just skip that for now. Okay, so let's start with getting an understanding of the mental health scene in Pakistan. So starting big picture, in South Asia, approximately 150 to 200 million individuals are estimated to be suffering from mental health disorders. So now when we zoom into Pakistan, mental disorders contribute to more than 4% of the total disease burden. However, due to the limited mental health research in Pakistan, it's likely that this percentage is actually significantly underrepresented. And Pakistan has a ratio of 0.19 psychiatrists per 100,000 people, and that's one of the lowest ratios in the entire world. So to explain some terminology, telepsychiatry refers to the adaptation of seeking psychiatric services through digital communication with mental health professionals. So as a result, telemedicine allows psychiatric services to be more accessible and cost-effective. The region that our project focused on, as mentioned earlier, was the Dadar region, which is in the KP province of Pakistan. This area is prone to natural disasters such as floods and landslides, which contribute to significant psychological distress, especially among more vulnerable groups of the population, such as women, children, and the elderly. Due to the socioeconomic impact of the pandemic, COVID-19 is relevant to this discussion because it increased the mental health burden in Pakistan. However, it also increased the demand for online healthcare services in Pakistan. And for many communities, especially those in the rural setting, there really is no other option. So to start the project, we first conducted a literature review. So on the slide, I have a screenshot of our Prisma flowchart, which basically shows our process for selecting the studies that we included. And our review included both qualitative and quantitative studies, case reports, and meta-analyses. Our study had two objectives. The primary objective was to quantify the prevalence of mental disorders in Dadar by using telemedicine, but the secondary objective was to determine the efficacy of these telemedicine services in highlighting mental health issues in the community. And so just going off of the objectives, our primary hypothesis was that telemedicine can be used to quantify the prevalence of mental health disorders in disaster-prone areas where access to such services is very limited. So going into the methods, one important thing to note is that this was a retrospective study, and this means that all of the data was actually collected prior by Sehat Kahani to when the study occurred. So my partner and I didn't personally collect this data. So as mentioned earlier, the setting was the Dadar region, and the target population was the patients who accessed the facility's psychiatric services. This study used two sampling methods. The first was non-probability sampling, and this means that all the participants that were selected were based on non-random criteria. And so one important thing is that this method has a higher sampling bias. The study also utilized purposive sampling, in which the community of interest is studied based on the characteristics of a population and the objective of the study. So in this case, the community of interest lacked accessibility to effective and sustainable psychiatric services. And this is important for determining the effectiveness of telemedicine in bridging this gap. So no demographic was excluded from this study because we wanted to identify the most vulnerable subgroups, which serves a beneficial purpose in determining the specific psychiatric needs of that community. In addition, only participants who completed all of the data fields were included in the study. Again, this data was already previously collected by Sehat Kahani, so it's considered to be secondary data. Patients were selected for the study through initial screenings during consultations at the psychiatric facility. Many patients in this study were brought to the facility by family members or community members after displaying psychiatric symptoms. The patients were then connected with the psychiatrist through telemedicine, and the consultation took place through the Sehat Kahani application or Skype. Recorded data included information such as their age, their marital status, their education status, symptoms, and other initial observations the physician made during the consultation. This information was then used to diagnose the patient, develop an intervention or treatment plan for the patient. Okay, so going into the results. So there were numerous factors that we analyzed, but for this presentation, I'm just going to highlight a few of them. We found that the majority of the patients in the study were male. The relationship status, most of them were married, and most were between the ages of 30 or 40. We also found that the relationship conflicts were the largest psychosocial stressor behind their conditions. Most of the patients were not suffering from substance abuse, and a large percentage of the patients had also received no education. So throughout this study, patient privacy and confidentiality was maintained. Informed consent was also obtained from all participants, and in accordance with HIPAA regulations, the patient's identities were kept confidential and their records were kept secure. One limitation is that the non-probability sampling method is not representative of the entire community population because it does not include those who were not brought to the healthcare facility. This could be due to stigma in the community or whichever reason, but the point is that it's not representative of the entire community. So a future study should use random sampling methods to ensure they're getting a more representative sample of the population with fewer biases. And this would help us get a more accurate picture of the mental health scene in that community. So to conclude, the issue is that there is currently a gap in the research regarding the prevalence of mental health disorders in disaster-prone communities in Pakistan. Our study aims to fill that gap by using telemedicine to assess patients and identify the most vulnerable groups in the community. And the findings can be used to create more effective post-disaster interventions and treatments that target the specific needs of the community. So just to end, I wanted to say thank you to everyone for listening. Thank you to the Sehat Kahani team for their excellent guidance and mentorship during this entire fellowship. And thank you to the APF community for providing me with this amazing opportunity and experience. So I think that's all.
Thank you, Zainab. Let me ask you one follow-up question, which is,
Sure.
you said you're on the pre-med track and there was a good amount of research here and learning about methodology. Like what was, what's something new that you learned from this experience of doing this kind of work that will help you as you move forward in your professional path?
I guess one key skill that I learned throughout this fellowship was a lot of times in all our classes or throughout the college experience where we have to read a lot of primary research papers and articles, for papers, for whatever reason, for classes. And in those papers, you get the final result. You see what the study, taught you, and you're like, okay, this is what they did. But it doesn't really give you an appreciation for like the scientific method behind it. Like, how did they come up with the question, and how did they narrow down what exactly they were studying? And so through this process, this fellowship, I was able to get like a better understanding of that method, of how a whole study, how it's formed, and the components that go into it. And so at the beginning, we conducted the literature review, and that's where we kind of had to come up with our idea. I remember I went into it with like, I want to study this and this, and I also want to address this aspect, and also want to talk about this. And then my mentors were like, that's great, but for this project, you're going to have to really narrow it down to like a key factor that you want to study in this like larger big picture. So I guess understanding that process, gaining experience, having the guidance of the mentors and Dr. Sar and Dr. Ifat, I think was a really incredible experience that the skills that I gained from that will be useful for like wherever I go.
Yeah, I agree. I think this bucket of skills and learning it in a very practical way and in a way that's related to a real world problem that's unfolding before your eyes is going to be, you've learned stuff from here that's going to be applicable into so many other things that you take on, projects or tasks or assignments. So that's wonderful. What about, one more question for you, Zainab, what about any of your assumptions or views about mental health in the South Asian community or within like the Pakistan context or even amongst Pakistani Americans? Did this make you think differently about any of those issues?
Yeah, I think one very beneficial aspect of this fellowship were the speaker sessions. I thought that was excellent. We looked forward to those every session. And I remember one speaker, I'm forgetting which one, I apologize, but they mentioned the importance of using of understanding the cultural context and being culturally sensitive when addressing certain issues within a community. So I think before this fellowship, I thought when talking about mental health, anyone could, approach any setting and just use common terminology that I'm used to, that a lot of us in the West that we're used to using. But they just explained that when you're talking to certain groups of people who might have limited access to these services or awareness of behind mental health issues, they might not be as receptive. So it's really important to speak using terminology and speak in a way where you're finding the common ground in the way that they will also understand. And so I think that type of being very sensitive to the current context of where you are, I think is like a skill and like a lesson that I think was really stressed in this fellowship, and I'll like definitely consider in the future as well.
Wonderful. Thank you so much, Zainab. Congratulations. And we're so proud of the work that you did, and you presented it beautifully. I wouldn't have been able to do such a good presentation when I was in college. So it's very inspiring to see. Okay, we'll have a few more questions on this topic at the end, but let's go to, why don't we go to Salman and Kamran next? Okay. And go ahead and share your screen as you need to. Okay, thank you.
Hi, everyone. My name is Kamran. For this fellowship, my partner was Salman, and we'll introduce ourselves in a little bit. But the title of our presentation is Evaluating Clinicians' Barriers and Facilitators in Adopting a Telemedicine System in Pakistan. To introduce myself, my name is Kamran Jilani. I was born and raised in Queens, New York. I recently graduated from Cornell, where I studied biology and nutrition. Currently, I'm working in a research lab where we're studying genomics and personalized medicine. And in general, my interests include public health and healthcare management. And ultimately, I want to go into medicine.
Hello, everyone. I'm Salman Iqbal. I was born in New York, and I've lived in Houston since 2007. And I'm currently a senior at the University of Houston, pursuing a major in finance and a minor in biology, as well as on the pre-med track. And my primary interest is kind of the intersection between healthcare and business. Over the summer, I did a research project regarding the supply chain of COVID-19 vaccines. So that sort of area is what I want to get into in the future. And ultimately, my long-term goal is healthcare as well, like being a physician.
So today we'll start with our introduction and provide some background information. Then we'll move on to our methodology, results, and then we'll end with a discussion of our results. So to define some important terms, telemedicine is known as the delivery of healthcare services at a distance using electronic means for the diagnosis, prevention, and treatment of diseases and injuries. That's the definition we're using in our study. Telemedicine has flourished in developed countries by serving as a cost-effective solution to fulfilling basic health needs, especially throughout this pandemic. It eliminates travel time and costs, making it especially useful for eliminating the healthcare gap between urban and rural populations. So contextualizing this to Pakistan, 63% of Pakistan's population lives in rural areas where it's difficult or close to impossible for physicians to practice with adequate resources. The WHO has designated Pakistan as one of 57 countries that fall below the necessary standardized threshold for delivering essential healthcare services due to the 1 doctor per 1,000 population ratio. So telemedicine is a service that can potentially serve as a cost-effective and efficient solution to alleviate Pakistan's healthcare issues. The research question we focused on was what barriers and facilitators do clinicians face when adopting a telemedicine system in Pakistan? Our rationale was that previous studies have focused on the patient's perspective, but not on the clinicians themselves. And also prior studies have focused on countries with very strong healthcare infrastructure and or unified healthcare systems. We need a more comprehensive understanding of how this applies to Pakistan. So our objectives were to identify key barriers and facilitators, explain how these barriers prevent successful adoption, highlight the importance of addressing these barriers for successful telemedicine implementation, and highlighting how potential facilitators can be maximized to contribute to greater telemedicine adoption. Before we did the actual study, we performed a lit review with the following inclusion criteria: that articles were selected and were conducted in English, conducted in Pakistan or a developing country, or includes reference to Pakistan, conducted post-2005, and focused on healthcare providers, and obviously utilized telemedicine. Our exclusion included non-English studies, studies conducted in a non-developing country, or studies that focus solely on the patient's perspective of telemedicine. So this Prisma diagram shows our sources for the lit review. We really wanted to use sources based in Pakistan, such as Pakistan Research Database and the Journal of Pakistan Medical Association. And so we found a total of 18 articles and ended up including 11 in our lit review after applying the inclusion and exclusion criteria. These are the barriers we identified: time constraints, technology and digital literacy, infrastructure, both physical and technical, communication, privacy, and facilitators included the growing tech industry in Pakistan, and efficiency, which we're defining as time saving. Our hypothesis was that we would see barriers similar to what we found in our lit review, such as privacy, communication, infrastructure, technology literacy, reimbursement, lack of healthcare centralization, and time constraints. And facilitators would include the growing tech industry and continuous training in telemedicine software. The sampling frame included a target population that were clinicians, which includes but is not limited to physicians, nurses, pharmacists, and other healthcare professionals. The data collection tool was a survey questionnaire consisting of 2 demographic questions and 20 questions gauging telemedicine experience, difficulties, and facilitators. And this questionnaire was distributed by the Sehat Kahani team over a period of 14 days on Google Forms. The demographics of our responses from 43 respondents revealed an average of 7.2 years practicing medicine or healthcare. The top 3 categories of respondents included general physicians, practitioners, and family medicine physicians. Respondents came from a range of specialties, including radiology, pediatrics, nephrology, and gynecology. The rest of the results will be presented by Salman.
Yeah, so the results can kind of be broken into several categories. First of which is knowledge of telemedicine, which kind of gives us insight into how familiar respondents were with telemedicine technology and their general understanding of it. And when asked to what extent are you familiar with telemedicine technology, 41.9% of respondents reported being very familiar with telemedicine and 16.3% as extremely familiar. However, when asked, the majority of respondents reported that being moderately or very familiar with telemedicine guidelines at 71.2%. An almost equal percentage of those respondents reported being either moderately or slightly familiar with telemedicine in other countries, and 11.6% reported not being familiar with telemedicine in other countries at all. So as for the next category, which is perception of telemedicine, that kind of gives us insight into how telehealth systems are viewed by respondents and their overall opinions on the field as a whole, especially with regards to its efficacy and efficiency. And the majority of respondents reported that telemedicine should be increased at 91%. And when asked if it can save time and money, 32.6% strongly agreed, while 60.5% just agreed. The majority of clinicians also reported that patient privacy is ensured through telemedicine at 81.4%, which is promising considering how big of a topic privacy concerns have become over recent years. Yeah, and as for the physical and technical infrastructure aspect, 29% of respondents did report physical infrastructure as lacking. Similarly, 21.4% of respondents reported that technical infrastructure, such as bandwidth, computers, software, was not available. So we can see that there's a degree of belief that the infrastructure is not quite yet fully there for telehealth systems. However, as for willingness of telemedicine, a very convincing 86% of respondents listed that telemedicine systems can be integrated into the current healthcare system. So there's a degree of optimism in that regard. So looking at it overall, the data we found partially supports our hypothesis. Some of the barriers we did find included a lack of physical and technological infrastructure in place currently to support telemedicine. However, privacy, communication, and time were not considered barriers. On the other end, facilitators included the potential for cost savings as well as greater efficiency and time, which were expected. In spite of the findings, limitations should be accounted for when considering the study. The survey was only conducted over a period of 14 days, which limits the number of responses received. And the sample size of the survey wasn't very large either at 43. Additionally, it was written in English only and may not have been interpreted by clinicians not fluent in the language. And because the survey was distributed by the Sehat Kahani team, there may have also been selection bias among the respondents, with them being more familiar with telemedicine due to their employment at a telemedicine-based company. So overall, the impression of telemedicine was very strong amongst the clinicians surveyed, and the attitude towards the field is mostly favorable. As we saw in the results, 86% of them reported that telemedicine can be implemented in Pakistan within the existing system. So with the right allocation of resources, telemedicine can potentially serve as an effective tool to combat healthcare issues in Pakistan, particularly with those living in less urbanized areas who are affected by like spatial health inequality. So as for future recommendations for additional studies, these include an emphasis on more open-ended questions and surveys, and actually conducting interviews with the respondents to get like a better picture of their opinions towards the field. And additionally, expanding the base of professionals can help create a more diverse group of like a diverse data set and give us a better understanding of how these variables influence different groups. So then lastly, we would just like to express our thanks to the Sehat Kahani team and APF for showing their support and all their mentorship during this valuable fellowship experience.
Thank you. Wonderful. Kudos. Another very interesting set of research findings. So I like that when you were talking about kind of the findings and what maybe some possible limitations were, that you were very kind of honest and clear about kind of what more work needs to be done, and maybe the potential biases amongst the respondents. And I think it's usually that phase of research where you can find more ideas to do more future work. And so I want you to, both of you, just to comment on this or elaborate on kind of what aspect of the findings would you want to explore further. So for example, I think you did mention like maybe having more diverse respondents or a larger sample size, but I would love to get maybe something more specific from each of you, and like what is there more research to be done on, say, access to technology when it gets to different parts of the country, if you're trying to diversify, for example. Either of you could go first.
I would say getting interviews with mental health professionals. That's something I would want a lot more research on, because through my literature review, what I found was that patients who are seeking telehealth for mental health issues perform or are able to be more open if they're not in their home. And so their environment makes a huge difference. And so I would want to learn more about that perspective from like a mental health professional. But unfortunately, we didn't have that many. So that's one direction for future research.
Thank you. Salman?
Yeah, I'd say kind of going forward, we kind of touched on this a little bit, but maybe kind of like advancing more on that is like the spatial inequality aspect of it. Like you said, there's certain parts of, there's like a technology gradient, if you could say, like throughout the country. So like in certain parts where there is not as much access to like technology, how can you kind of get them involved in telemedicine as well, and kind of find that balance between implementing technology and then also giving it to people who can use it. So I think that's something that further research should be done on.
And in the chat, Dr. Uzma Iqbal, who's one of our board members, has written, despite being an advanced country, there are also barriers for both physicians and patients in the US. And so final question for both Kamran and Salman is, you both mentioned you eventually want to practice medicine or go into healthcare. Has this made you think differently, or has your thinking on telemedicine kind of in the States evolved at all in doing this project?
I guess it's kind of interesting to see like the take on telemedicine implementation in another country and the parallels that we can see here, because like at the same time, like there's also a inequality gradient in the United States as well. So that same issue in Pakistan, where it's kind of, it might be hard to implement telehealth for people who don't have as much access to like internet or technology. Kind of those solutions you find over there could be implemented here as well. So it's not like the two are mutually exclusive. There's definitely some overlap in terms of, you know, issues regarding the implementation.
Thank you. Thank you. Well, congratulations, both of you. This was another wonderful presentation. We're very proud of you. Well done. So let us now go to Shmail for the final presentation. Please go ahead.
Can you guys see my screen?
Yes, we can.
The PowerPoint?
Yes.
Okay, good.
If you want to put it in display mode, yep.
Okay. Okay, well, assalamu alaikum. Hi, everyone. I'm Shmail. I'm Shmail Guman. I'm a medical student currently, a second-year medical student at the Lake Erie College of Osteopathic Medicine. I did my undergrad in biomedical engineering, and then I actually worked at a telehealth company for about a year before I then went to medical school. And it was during that year that actually the COVID-19 pandemic hit, and I was involved heavily in training providers to use our service and how to kind of brand ourselves. We were more of an electronic medical records company. And so we had that platform. We added video consulting has always been a part of telehealth or a part of medicine for a while, but the pandemic really did highlight the need for it. And so I was heavily involved in that. That's kind of my interest in telemedicine, and my interest in Pakistan global health goes back to my undergrad. I did a couple of projects there, and I've, in my future career as a physician, I hope to be involved in some global health work as well, and especially giving back to underserved populations. So just to start with my project here, it's I was fortunate enough to be given this opportunity by APF and by the people at Sehat Kahani, and it is I have the title here, Evidence on Tele-ICU Clinical Outcomes and the Potential for the Implementation in LMICs, which are low to middle income countries. So I did a reviews of the literature as well as a case study. So the questions I'm asking here are that, do tele-ICUs provide improvement in outcomes? And what are the potential barriers, as Kamran and Salman touched on? And specifically, what do low to middle income countries, what challenges do they specifically have, as well as the economic feasibility? So these questions are asking very poignantly, what does the literature currently say about tele-ICUs? And it's really touted as a big solution to the COVID-19 pandemic. But we live in an evidence-based world, and we want to know whether the evidence in the literature actually does point to improved outcomes, and what are factors that can affect the outcome of implementing tele-ICUs. So first, I want to go into what exactly is a tele-ICU. If we look here, tele-ICUs, it's really a fancy term for connecting interventionalists and critical care specialists to patients in rural areas that otherwise would not have access to that. So if we see here the telemedicine, as Kamran and Salman defined it, it's basically leveraging audiovisual capabilities to patients. And we have two real models here. The virtual consultant model and the centralized hub model. So the centralized hub model is kind of what you see a lot of in the US, in big academic centers, where you have a, can you guys see my mouse? Maybe not, I don't know. But you have a centralized hub here.
We can see it.
So you have a central hub that connects with other consultants, and these represent hospitals. And the central hub is where the critical care specialists and other clinical staff are. And so they take care of multiple different hospitals at the same time. And what's really great about this technology, and what makes it more technologically complex, is that you have a live continuous stream of the vitals and video feed of the patients to the intensivists at one area. And so because of that, they can actually manage patients at multiple different hospitals all at the same time. The other model here is the virtual consultant model. And what makes this different is that it is more hospital centric. So you have really one hospital, and they're virtually consulting with a critical care specialist, as well as other consultants, and the final clinical decision-making authority is with them. So why is this important? I just want to give a little bit of a brief background on the COVID-19 pandemic and its impact specifically on care medicine. So in Pakistan, only 1.57% of the population is fully vaccinated, compared with, I think it was about 50% here in the United States. And now we've seen, at the time I was writing this, the Omicron variant wasn't discovered yet. And we had said, it was actually predicted in the literature that we're going to keep getting more. I think the Delta was around. So we're going to keep getting more and more variants. And with only such a low vaccination rate and a lack of ICU beds across the country, it was predicted that this was going to be still a huge problem in getting patients who have critical need care to hospital beds. And specifically, we're talking about ICU beds. You can see there it says 0.71 ICU beds per 100,000 population. In the United States, it's about 27. That's a huge difference per 100,000 people. And the best country in South Asia is Nepal at 2.7 ICU beds. And as we know from the pandemic here, the reason this is so important is that the COVID-19 virus, really debilitates people, and is a respiratory virus that necessarily dictates that you need critical care immediately. You need to put on supplemental oxygen, and you need to put on a. So this is why ICUs and ICU beds and critical care specialists who have experience and have training actually in specifically dealing with patients who are having respiratory issues, they're needed the most. And of a survey conducted of 151 hospitals in Pakistan, only 28.7% of those hospitals actually had isolation rooms that they could use for COVID-19 patients. And only 12.1% of those ICUs were managed by critical care specialists themselves, which are really damning numbers. So clearly, we see that tele-ICUs can solve this problem. And so just to go into a little bit of the methodology I used, first I narrowed down using search terms telemedicine into the PubMed database. And I was looking for records that had anything to do with tele-ICUs, whether they were in low to middle income countries or in the Western countries. So I got about 10 after excluding the criteria and getting only relevant research studies. And what I was specifically doing was looking at review studies. So my methodology was that I was doing a review of systematic reviews, because the actual evidence, and according to our time constraints of what we had for 8 weeks, the actual body of literature of patient data is extensive in the actual literature. So I think this is a good time to go into what Sehat Kahani did in their own tele-ICU case study. They did exactly kind of what I was talking about with the virtual consultant model, where they leverage their telemedicine portal and their telemedicine platform that they already had, and they were connecting intensive care specialists to ICUs. On top of that, they also had a preliminary phase where they trained their physicians, about 4,500 doctors and 500 mid-level staff, on how to use the portal and educating them on telemedicine. Overall, they treated about 2,000 plus patients who were treated and actually recovered. So I want to go into a little bit of the results and discussion from the literature review. In my review, I had 6 different meta-analyses and studies, and all of them actually found a reduction in ICU mortality. So 100% of my studies found a reduction in ICU mortality post-implementation of tele-ICUs, and 80% found a reduction in hospital mortality, 80% found a reduction in ICU length of stay, and then only 40% found a reduction in hospital length of stay. So one of the conclusions that we can take from I'll get into that a little bit later, because this is actually an interesting dynamic of why the hospital length of stay actually increased, or it seemed to not be of that much effect post-implementation of tele-ICUs. Another aspect I was looking at was social and financial factors. Clearly, we can see financially, there's a lot of work that needs to be done in literature, because the cost to implement was about $50,000 to $100,000 for the first year per bed of ICU. And this is mostly looking at the centralized hub model, which used continuous vital monitoring. So obviously you need a much grander scale of technology. And including the virtual consultant model, I think the Sehat Kahani case study really demonstrated how easily that can be implemented. And the cost savings are very ambiguous at this time. Some people, and there were only about 2 studies that actually even looked at these metrics. Only about those 2 studies found that there was a cost saving, actually an increase of cost of $5,600 per patient, and some of them found $2,600 savings per patient. Interestingly, let's look at a little bit of what the staff acceptance was. So staff acceptance was a big part of whether the technology will succeed. And so a lot of people in surveys conducted post-implementation found, a lot of the staff and providers found satisfaction among the implementation of the tele-ICU, and actually they found it as an enhanced opportunity to learn. I want to look at some of the challenges. I think a lot of these challenges were touched on by Kamran and Salman, so I won't go into too much, but we have to look at it, and there are plenty of challenges on an individual to governmental scale, and it's a multi-dimensional really challenges that are presented. So logistical concerns could be, as they were talking about, tech illiteracy among these staff, and access to technology, which is something that Sehat Kahani reported in their own case study, that there wasn't access to even technology. Forget about technology. In the rural areas where this will actually be most beneficial is access to medical equipment, running water, electricity. So these things really have to be ironed out, and those are also governmental issues as well. Governmental issues also include, I would say, software regulation. When you have so much HPI, the health data going around, I think it needs to be regulated on a governmental scale, especially in terms of privacy and security. And then also, I think clinical concerns was that we talked about an increase in hospital length of stay. I think that's because once you have intensivists triaging in the ICU, they send a lot of their patients who don't actually need critical care management to the general floor. And so you actually see an increase in the hospital length of stay for that exact reason. And so there's also a lack of critical care training programs in Pakistan, as in the US, but really specifically in Pakistan as well, that don't actually emphasize how important it is for physicians to be trained in critical care. So for my last slide, just a conclusion. I know I ran a little bit over time. Sorry about that. But my recommendations would be to implement initially a virtual consultant model in low to middle income countries. I think it's very inexpensive. And I think Sehat Kahani in their case study or in their project demonstrated how easily it could be done from a cost perspective, because what you need to do is train clinicians just to use resources that they already have in their scope, like smartphones. And I think another big thing is that it's also tackles the other thing of education. So it educates people into how to use technology so they get over the fear factor and decrease their negative attitudes. And then some of the other things was that, as I said, leverage their telemedicine platforms. And there was a big heterogeneity among the studies that they themselves reported among data and how people report data for tele-ICUs and their, I guess, clinical effectiveness. So another big thing to take away from here for researchers and administrators alike is to standard data points among patients before and after implementation, which includes like length of stay and mortality. A lot of hospitals don't actually want to report that for one reason or another, depending on their incentives, what they're going to get back. So I think these are all interesting insights I've gotten from the case study and from the literature review overall. So thank you to Sehat Kahani, thank you to APF for giving me this opportunity, and I definitely learned a lot.
Wow, Shmail, wonderful presentation. Really good job. And I love, there's some comments like this in the chat too. I love how you visually presented the findings and the insights. And I may be coming to you to do some APF graphic design work if you're, so hopefully you'll say yes. But everything was,
thank you.
Yeah, no, I think communication is really key with this kind of dense information when you're dealing with research and data, and sometimes visual communication is the most effective. So I want to I just want to go back to the last slide where you had your recommendations, and you included, recommendations for let's see, researchers, administrators, and policymakers. So I want to just get your opinion on this. Like, you and your fellow, the other fellows, like you're all interested in going into the practice of medicine, right? And into the healthcare market. But did this experience of doing research make you think differently about kind of the policy relevance of the work and how your career as a medical practitioner would interface with policy? I know that you're interested in global health issues, and a lot of those would be, I think, very policy relevant. So I'd just love to get your big picture thoughts on kind of the policy angle of doing this kind of work.
Yeah, I wouldn't say I'm much of an expert in policy at all. I wish it's something I had looked more into in my undergraduate. I have a lot of, I guess, reserve about policy and governmental work because, I before going even into medical school, I really was interested in politics and all, and going into that route and foreign policy. I just was turned off by the fact that I felt I was so small and I couldn't do anything in such a big scope. So I feel like maybe in healthcare, you can, it's very science-based, it's very evidence-based. We can, it's important to do even like this that shows what are exactly the clinical outcomes, so that these things, when you present it then to policymakers, it's evidence staring them in the face that they, at least you can say, well, I've come up with the evidence and now it's your job to take that and go forward with it. And I think it, really puts a compelling argument out there, because we always, you could even criticize this study by saying, well, of course it's, tele-ICUs, of course is going to help. Like, why is that even a question being asked?
Yeah.
But when you present the evidence and really look at, is it increasing, does it decrease mortality, and look at those big picture questions backed by your scientific studies, I think it is compelling in a policy angle. And it's something, from the policy standpoint, how you actually make that change happen is beyond me. And I'm, hopefully I'll learn more about that later. But yeah, definitely. I don't know if that answered your question, but that's
Yeah, no, it did. And the policy relevance of it really spoke to me, because when you talk about things like costs, right, for the consumer, and then costs for the provider, and inevitably, governments offer certain kinds of services as well, right? So the private sector is often a competitor in some ways, but I think that there's a lot of room for the public and the private to inform each other. And so the research like this is really important in shaping the views of policymakers. And my goal would be for all of you to continue to grow in your ability to have that policy literacy as well as your specialty in medicine as well, right? So I think this is the benefit of this kind of work. So thank you so much, and job well done.
Could I add really quickly?
Sure.
That, what you were talking about, how people fund studies like this, it's even when we saw differences in the cost discrepancy between whether you save costs or not implementing this, a lot of that was correlated with whether these people were associated with the vendor that they were getting their software from. So, really, in the end of the day, money drives everything. So I feel if, you present the evidence there and you present as something cost effective for policymakers, it will drive them, and they'll give you money to generate the data for something. Maybe they're just whatever they're thinking, but you're passionate about it, and it will be something beneficial for people.
Yeah, I agree. Thank you for that. So Uzma has a comment here. I'm going to put Uzma on the spot. Uzma, would you like to, could you speak? Could you share your glorious presence with us for a moment as program? So Uzma is also the chair of the APF programming committee. And so she's very instrumental in helping us design and shape these fellowship experiences. And she's also a very strong proponent of policy literacy. Uzma, you want to make a comment?
She probably
can. Do we need to give you permission?
Yeah.
Hold on a sec. All right, let me allow it to talk. You got it?
Yes. Can you hear me?
Yes.
Okay. All right, perfect. Well, first of all, amazing work. And thank you, Sehat Kahani and the leaders, for providing this platform for the students to learn from their experiences through this. And I'm sure that even if these fellows choose to stay in US in whatever capacity, this will be an amazing experience for them. So, just like as a person who went to medical school in Pakistan and then I'm practicing in US, I'm very aware of all of the challenges that you guys have talked about. But one of the things which I want to really enhance is the importance of people who understand medicine and the areas associated with medicine to engage in the policy literacy. And I think if we are not, the way they say, if you're not at the table, you're on the menu. So I think we've been on the menu for a very long time. So all of the fellows, you are actually in APF at an amazing organization where you have access to policy literacy through Shamila and Shamila's policy, fellowship programs. So you don't need to go any further than where you are and engage with Shamila about how you can pursue your interest. May not be another career, but at least interest. So you know the language to help taking an idea. There's a pipeline from an idea to policy, right? And then I think that's where you can learn in APF that a lot of other organizations don't offer you. Shamila, you want to talk about that? Do you think this will be beneficial for them?
Yeah, so I mean, there's definitely this link between this kind of fellowship experience and its policy relevance, and then what we try, what we try to teach in our foreign policy fellowship. And I want to give you a concrete example of like how this research that you've done in this project with Sehat Kahani can translate into something that has foreign policy significance. So, and it doesn't have to be just with Pakistan, for example. So the United States government has bilateral relationships with most of the countries in the world, right, with the exception of a few like North Korea. And so in those relationships, there's always buckets of foreign aid assistance, security assistance that are allocated to, for various national security interests and international development goals. And having kind of an awareness of the effectiveness of, say, telemedicine in Pakistan and its impact on certain communities like women or underserved populations, like that can very quickly become a priority of the US foreign assistance agenda because of how, whatever the administration has identified as its priorities, right? And usually governments are looking to make a positive impact when it comes to development agendas in other countries. And they're also looking for good partners who are globally minded and who, are building bridges such as, and this project, this fellowship is a good example of that, right? And I know that in the past, we've had these fellowship conversations and our colleagues and peers, friends at the State Department have joined because they want to know what kind of work is being done on these issues in Pakistan, because they are of importance to the US government and in various multilateral fora as well. We talk a lot about these issues at the United Nations. We're part of the Economic Social Council, ECOSOC, at the UN. APF has a membership there as a civil society organization. And these are all really important. These are important themes and dynamics and successes for the international community to know about what's happening in Pakistan. So your research becomes all the more relevant on a global stage as well as the bilateral stage. And we have a great partner to do it with. So we couldn't be more fortunate. I want to say one more thing about our partnership, and I'm going to turn it to Sarah to say a few closing words. So everyone's presentation today was amazingly organized, very thorough, very clear, very structured. And, I saw you all develop along the way. And I think at various points in time, like, you were supposed to learn stuff here. So at various points in time, it might've been a little difficult or maybe, challenging in certain respects, but we don't get good presentations like this unless you have good guidance and good mentors and you've put the time in, and it shows. And I know the work that it takes for fellowships. We run a few of these, and Sarah and Ifad and to the whole team at Sehat Kahani, I'm so grateful on behalf of all of APF. We're so grateful for the care and nurturing that you've given to our fellows, because you've also given them an experience of Pakistan and what it means to be, in Pakistan today and to do good. And it's very different than what you see, when you just read the newspaper. It's just not enough, right? So this is really special for everyone. I want to thank you for that. So Sarah, please, I would love for you to say a few words. And then I'm sorry, I meant to go to you earlier and I didn't. So I would like you to say something as well. So maybe we go to Ifat first and then we can close with Sarah. Sounds good? Okay, go ahead, Ifat, please.
Thank you so much. First of all, I think the presentations were amazing, and the heart that all of these fellows put into their work definitely means a lot. I think all the researches will be very useful for us as well. So with every fellow that joins in, there's a lot of learning at the organization also. So we get to also learn a lot from these students. They bring in a lot of knowledge, a lot of information, and I think the cross-cultural mix that we often create adds to a lot of learning for us, as well as the buddies that we create at Sehat Kahani. So I think that learning's great. We would really love to host some fellows physically as well this year, hopefully, considering that, the COVID situation, hopefully, inshallah, gets better. But I think if they get an opportunity to come to Pakistan, they will have and even more enhanced flavor of the kind of work that community health, telemedicine, and the digital healthcare space is going to give in its entirety. But I think congratulations to all of these fellows. Despite the difficult times that we worked in, despite all the time differences, they were really thought in their work. They were really active. They were really engaged, always with the buddies. And I think they put a lot of heart into creating that entire research program. So we are very excited to have them, and looking forward to be working with them in some capacity or other in the future as well as APF. So congratulations to you, Shumaila, for pulling off this amazing fellowship. I think the work that you are doing in engaging the future generation based out of Pakistan and kind of bringing them back to the roots, and constantly making them in touch with what Pakistan is and what work is being done in Pakistan. I think that's very important and necessary for the upcoming generation. So thank you so much for this amazing work.
Thank you. Thank you. That means a lot. Sarah, please go ahead. Final words.
Yeah, I think I just want to second, if for a second, that we get a lot of fellows in the company, and APF fellows always stand out. And I'm not just saying it because we're on the call. They really do come with a superior quality. They're hardworking, they're engaged, they're very professional. They ask the right questions. They give us a tough time if we are not giving them time. And I think this happens because of the pre-screening process, which also is another aspect of the fellowship altogether, that who are the fellows that are coming into the fellowship and how they are matched with the company. So I think the APF team does and spends considerable time in making that happen. So thank you for the pre-screening process. As always, these 5 people were amazing, but I think their growth in the fellowship, as you mentioned, is amazing. And how they worked in a group, because this is something we tried for the first time, that 2 fellows work together on one group, on one research project. So, and this is also difficult to pull through with different time zones, us being in Pakistan, they being in 2 different cities. So I think they pulled in a lot of courage to do this. So I love the presentations. I think they were very structured. They all represented their results amazingly well. I would not have been able to do this when I was presenting my final fellowship presentation. So great work done, guys. And I think I just want to take a moment and thank someone very special who was a guru to all of these during their fellowship. So Mehak Merchant, who is our research and grant lead in the company, she has overlooked all their work, right from their descriptive analysis to their results, to their backgrounds, to their literature reviews. She's given them feedback over time. She was also expecting a baby in this time with a young one. So she was already very consumed with all the work that we were giving her in the company. But I think she was able to make a lot of time and effort in making sure that these results come out, that she guides them on the kind of results and analysis, because this is something which is new for the fellows as well. So thank you, Mehak, for all your hard work, and all the other buddies as well who are attending the call. I think Nida, Yusra, Ramiza, they were all very helpful and taking our time after or before work to help the fellows achieve and complete their research work. Again, I'm looking forward to host any one of you who wants to come to Pakistan and spend some extra time in Sehat Kahani even after the fellowship. We would love to continue and try to publish these researches as well. We've done it with one fellow in the past. So any one of you who's interested in publishing the work, we can always take it to an IRB in Pakistan for approval and get published. So that opportunity is open. And we also have other researches in which we invite fellows to work with. So if any one of you still has an interest, we can also keep working together, and looking forward to the newer cohort this time. Thank you, Shamila, and thank you, Sophia, for arranging this. It was great to see their work.